So thank you very much for logging in tonight to Fitting the Diseased Post-Surgical and Asymmetrical Eye with Corneal GP Lenses. My name is Randy Kojima, and on behalf of Precision Technology and Bausch & Lomb, I'd like to thank you for being with us tonight. And this should be a fun session to talk about how we use corneal GPs with some of the tougher eyes that we encounter. Now, historically, we thought that keratoconus was caused by eye rubbing. We also believed that by using a three-point touch or shared bearing design, a lens that effectively put pressure on the cone, that we might keep it from progressing, that it was a cure of some sort. So how many of these beliefs are true today? And that's one of the things that we're going to address tonight. Now, one of the major studies that probably was more profound than any other in keratoconus, at least in recent years, was the CLEK study, and that looked at about 1,200 patients over 15 different centers across North America. So the N size was large, and what they determined was that 80% of the patients fit with corneal GPs had a very flat fit. And of those patients that were fit with three-point touch or flat-fitting lenses, they had a much higher incidence of staining or scarring than patients that had apical clearance lenses. So in other words, these three-point touch methods were increasing the scarring and the staining that we were seeing versus patients with apical clearance lenses. So it may be safer to use apical clearance rather than bearing. So that was a big finding by the CLEK group. Now, as far as the incidence goes, we've seen studies that indicate it's as low as 1 in 100,000 patients or as high as 1 in 435 patients, but it's generally accepted that it's around 1 in 2,000 patients have keratoconus. Now, we also know that it's equally distributed around the world, so that kind of rules out gender, it rules out race, it rules out diet, and it rules out climate. So it appears to happen within all groups across the world equally. Now, there's a genetic component that's involved. We know that if you had a patient, a family member with keratoconus, that you were slightly more likely to develop keratoconus yourself. We know that keratoconic patients have some of the highest aberrations of any patients walking around, either post-surgical eyes, post-penetrating keratoplasties, and that, of course, causes a significant decrease in the visual acuity. And no surprise there when we look at the corneal topographies of these patients, and a good reason why so many of them are wearing wearing GP lenses in general. Now, Guide looked at the quality of life experience for keratoconic patients, and this was kind of interesting. They found that 96% of keratoconic patients reported they had some impact from the keratoconus. The reduction in their quality of acuity was an issue, or their contact lenses that weren't fitting as well as they would have liked, but there was some impact. And 40% noted that the impact was moderate to severe. This study also showed that there was no personality disorder associated. So if our keratoconic patients are maybe a little more needy, a little more high maintenance, they have darn good reason to be because of their poor quality of life scores. Now, Tim McMahon at the Global Keratoconus Conference presented on his topographic findings, and out of an N size of 300 found that 28% were nipple cones or centralized cones, cones that were relatively small, under 3 millimeters. 44% had oval keratoconus with sizes of between 3 to 5.5 millimeters. Patients with keratoglobus represented 6.7%, and keratoglobus patients were deemed to be those with cone sizes measured by topography of greater than 5.5 millimeters. He found that 5.6% were pellucid marginal degeneration patients, and that 14% of his cone eyes required transplant. and that 10% of the keratoconus was found in the superior hemisphere, not only the inferior hemisphere. Then the same fellow, Tim McMahon, at the follow-up meeting, Global Specialty Lens Symposium in 2009, found that the slit lamp signs were bilateral 80% of the time, and that 96% of the time the keratoconus could be diagnosed by the topographer. Now, there's been some reporting that keratoconus can be unilateral, but one consideration is that no other corneal disorder is unilateral. So is it really possible that that there could be patients out there with keratoconus in one eye only, and what we may find is that the thinning is relatively insignificant in the fellow eye compared to the eye that is definitely showing keratoconus. But pachymetry and posterior surface shape would certainly prove that out. Now, Tim also noted that if your thinning was 2 millimeters from the limbus, it's most likely pellucid. Now, many of us have a difficult time distinguishing either topographically or in terms of the pachymetry what is keratoconus and what is pellucid. And, Tim encouraged us to think about that which is very close to the limbus, 2 millimeters, might be PMD rather than keratoconus. Now, Reeder presented a poster at the British Contact Lens Association, and what she had looked at was the number of, the incidence of hydrops that was happening in her keratoconic patients. So out of 446 keratoconic patients, she noted a 9.2% incidence of hydrops. And it was interesting that the hydrops was highest in April, and that may be associated with allergy season. So is there an allergic component to the development of keratoconus or the advancement of keratoconus? That may be something to look at. Now, another study that was in a specialty contact lens practice, basically a clinical practice and not a research site, not an educational site, and what they found was in their 244 keratoconics, 54% were male, and then interestingly, 78% of the keratoconic patients were wearing contact lenses, 67% wearing corneal GPs, 4.2% wearing sclerals. So 71 or 72% of the keratoconic patients were wearing a GP lens of some sort, be it corneal or scleral. And that of their keratoconics, 21% had penetrating keratoplasty. But 65% noted eye rubbing as something that was routine to them, something that they were doing. So the eye rubbing was somehow associated with their keratoconus. Now, there was also a genetic component of 27% in this study, so it was rather high. Now, a number of researchers have noted keratocyte apoptosis as a possible major issue with keratoconic eyes, and what they call minor traumas like eye rubbing and poorly fitted contact lenses may be accelerating this cell death. So that's something for us to look at very seriously, that how much are patients rubbing their eyes, and how well are we fitting our contact lenses. So let's just store that one away for a second. Now, Christina Kenny has looked at the enzyme activity involved in keratoconic patients and found that KCIs have increased enzyme activities while they have decreased enzyme inhibitors. So the byproducts could be leading to increased thinning and then, of course, increased scarring as well. So she's looked very closely at what's going on with these enzymes, and so it's not just a mechanical issue that we're dealing with. We may be dealing with other issues as well. So this is being called oxidative stress, and researchers from around the world have encouraged us to use ultraviolet protection with our patients that are suspect keratoconus or keratoconus. that we're encouraged to minimize mechanical stress like eye rubbing and ideally fit our contact lenses. And of course, by controlling allergies, we may control some of the mechanical stress that we're creating. So oxidative stress is the term we're throwing around much more often today. And early in this webinar, we talked about eye rubbing. And eye rubbing is definitely something that appears to be a contributor for accelerating the disease, making it worse. Now, these terms are a little bit foreign to me. Keratocyte, apoptosis, enzymes, and oxidative stress are not something that I deal with on a daily basis, and so I've read up a little bit on it. And one of the papers that helped me to understand this a little bit better was Owen and Tulow's contact lens spectrum in 2011, and what they note is that these eyes have an inability to self-repair, which creates an increase in free radicals within the cornea, and without the ability to metabolize as a result of these free radicals, the collagen of the cornea is damaged and becomes weaker. And so therefore, the more damage that we do, either by mechanical stress in our contact lenses or eye rubbing, may also accelerate the problem for these keratoconic eyes. Now, how many patients require penetrating keratoplasty? Numerous studies have shown us that it's between 10 and 22% of patients require some form of penetrating keratoplasty or some form of transplant. And we know that's happening either because the keratoconus develops to the point where we can't fit them with contact lenses anymore, or more likely that we have such severe scarring that the VA has dropped significantly. Pramatic looked at the success rate and found that penetrating keratoplasty had a success rate of 90% for up to 18.8 years post-operatively, so it's fairly successful. Now, another study by Shanslin looked at the rejection rate of 18% was his finding, and that 4 diopters of corneal astigmatism, or refractive astigmatism, was common among most penetrating keratoplasty patients. So most of our patients will require some form of post-surgical correction, and we know that 50% of our penetrating keratoplasty patients require contact lenses, and usually it's GP lenses because of the degree of corneal astigmatism as well as its irregularity, that it tends not to be utterly regular corneal astigmatism. Now, what can we do? One of the things we know is corneal crosslinking, and some of the things we want to keep in the back of our mind is let's get these patients in for crosslinking before their corneas are thinner than 400 microns. Otherwise, there's potential damage from the UV to the endothelium. So try to get them in when they're starting to show thinning before they are less than 400 microns thickness. So our recommendations for our keratoconic pellucid Terriens patients for all these corneal thinning disorders is UV protection. We want to fit our contact lenses in such a way that we're not bearing on the ectasia and increasing these chances of this cascade of negative outcomes. And then control allergies if we can, and hopefully by controlling the allergies that will reduce the eye rubbing and that mechanical stress. And then, of course, cross-linking when we notice that keratoconus is progressing. Of course, not all patients are progressing. They stabilize it. Some patients stabilize early, some patients stabilize later. Just to follow the patient by topography and pachymetry is the way to go. So why are these diseased eyes so difficult to fit? And you look at all these topographies here on screen, and you can imagine how challenging some of these eyes, if not all of these eyes, would be to fit with lenses. Now, can we fit a patient with this kind of topography with glasses or soft lenses? When you look at this topography, would you think it's possible? And one of the things you might look at is the power within the pupil. We go from the flattest we can see at 40 diopters to the steepest we can see at 63 diopters. So there's a 23 diopter range of curvature within this pupil. So you can imagine the aberrations created for this particular eye. Now, if we were to put a soft lens over top of this eye, could we mask that irregularity? And you see the thickness of this soft lens. This here is the back of the soft lens, and here's the front of the soft lens. And then, of course, our cornea is here. So our soft lens is very much going to take the shape of this diseased or irregular eye. And to show you how the draping effects of soft lenses work, the left image is a corneal topography over top of this keratoconic patient with no contact lens. The right topography is on the same patient over top of a soft lens. And you basically see no effect of the soft lens in changing or masking the irregularity of this particular cornea. Now, there's been a number of soft lenses that have been developed for keratoconus. Precision Technology carries 2 of them, and they work quite well, and they work by using a great deal of soft lens thickness from 0.3 to 0.5 millimeters thick. Remember that a standard soft lens may be 0.06 millimeters thick, or let's call it 60 microns is a conventional soft lens. In the soft keratoconic lenses, they tend to be 5 times to 10 times greater in thickness than a conventional soft lens. And you can imagine how this mass of plastic may do a better job at masking the astigmatism or irregularity that might be there. And that can be seen in these topographies. The image on the left is a post-LASIK cornea, and that's without a contact lens. You see the oblate shape of the eye, the flat center, the steeper mid-periphery. This patient had kind of poor quality VA. There was a fair amount of aberrations for this patient. Then on the right, you're looking at the topography over top of the soft keratoconus lens. And what you might look at is the high and low in curvature. On the naked eye, we have about a range of power of about 2 diopters running across this white line here. Now, if we do the same thing over top of the soft keratoconic lens, we've cut that range of curvature back in half to only 1 diopter. So we're masking a fair amount of the irregularity with our thick custom keratoconus soft lens. Now the GPs, of course, being rigid, they're going to completely mask the irregularity of the anterior surface. If the keratoconus is posterior, then we're not going to fix that with a GP lens. We may mask a little bit of it, but we're not going to fix it. Thankfully, generally, most of our aberrations come from the anterior surface, so the corneal GP, being a perfect sphere on the anterior surface, should be able to mask most of the irregularity. Now, soft lenses aren't going to help this patient. We know that. We've got 23 diopters of power distributed within the pupil. We're going to have to go with the GP for this patient. But why is it that the keratoconic patient is so difficult to fit? Now, one of the questions might be, is it because they're so steep? The keratoconic patient tends to have much steeper flat and steep Ks. Certainly topographically, we've got a much steeper range of curvature. 58 diopters is the steepest curvature we can read on this topography. Now, in this case, a steep eye isn't necessarily a tough patient to fit. So the keratoconic eye isn't necessarily difficult because they're steep. They're more difficult, no question, but they're not necessarily more difficult because they're steeper than the average eye. So why is it that they're so tough to fit? Now, let's take a patient that's more regular. Here's a with the rule astigmatism. We've got limbus to limbus, a cylinder. You see the hot meridian runs from one side of the eye to the other, but it's fairly regular. Notice when you cut this this eye into hemispheres. The upper hemisphere is a mirror of the lower hemisphere, at least within the pupil. The nasal is a mirror of the temporal within the pupil. So this patient has very regular astigmatism, even though it's significantly high at 4.3 diopters. Now, if we put on a corneal GP, we can land the lens at 3 o'clock. You can see that on the graph here. So this dotted line corresponds with the graph showing you the fluid underneath the contact lens. So here's edge lift at 9 o'clock, landing at 9 o'clock right here, apical clearance, landing at 3 o'clock, and then your edge lift. Now in the vertical meridian, if we put a spherical lens on this cornea, spherical GP, we're going to have excessive fluid at 12 o'clock and 6 o'clock because this eye is so toric. So we put that lens on eye, and of course we have nice landing at 3 and 9 o'clock, but because we're putting a sphere on a very toric cornea, 4.3 diopter corneal astigmat, that lens is going to lift at 12 and 6. It's going to be awesomely unstable, rocking back and forth with each blink. So something needs to change about this fit. So we would use a Bi-Toric lens and then land the lens at 9 o'clock right here, land the lens at 3 o'clock right here, create a healthy edge lift on both sides, and a healthy amount of apical clearance. Then in the vertical meridian, we'd use a much steeper base curve to align to that steeper surface. And now we have a tear layer that's much more linear. It's not getting thicker and thicker and thicker. It's only increasing in thickness once you get to the peripheral curves. So when you place that lens on eye, you create a beautiful alignment with the cornea. Landing at 3 and 9 o'clock, creating lateral stability. Lens won't move nasal and temporal. We've got this nice little thin channel of fluid running all the way through the vertical meridian, and that way we can create good tear pump, good movement of that contact lens. So this patient was relatively easy to fit because the eye is symmetrical. We had lots of corneal astigmatism, 4.3 diopters of corneal astigmatism. So that wasn't the issue. The issue that made this easy was that this patient had a symmetrical surface. The two meridians, the principal flat and the principal steep, were 90 degrees separated, and the shape of the superior cornea and the inferior cornea were very similar, nasal and temporal very similar, so we could fit that eye with a Bi-Toric lens. But what about the keratoconic patient? What makes the keratoconic eye tough? And this patient we see has 5.2 diopters of corneal astigmatism, but that may be a bit in error in that we don't really see a defined steep and a defined flat meridian. We have an utterly irregular corneal shape or irregular astigmatism. Now if we place a corneal GP on this patient, we can land the lens at 9 o'clock here, land the lens at 3 o'clock here, create that apical clearance that we desire to protect the cone, and then a normal healthy edge lift. Now in the vertical meridian, we want to observe the fluid layer. Now from the center to 12 o'clock, that's here to here, you see the tear film is fairly linear. At least it's not getting thicker and thicker until you hit the edge of the optic zone. But from center to the inferior portion of the lens, notice the fluid layer getting thicker and thicker. And this is what makes the keratoconic eye challenging. It's not that it's steep, it's that it's asymmetrical. Notice how the surface of the eye heading north is fairly normal, heading toward 12 o'clock. The fluid layer here is fairly even. But from this point down, there's this massive drop in elevation giving us all this fluid. The lens is effectively vaulting a significant amount on this eye. Now this patient has hope. It has hope of a corneal GP working because we can land the lens at 3 and 9 o'clock and create lateral stability. We have a nice linear fluid layer keeping the lens relatively stable. The question will be, will we get a bubble down here, and we have to put a lens on to know. In this case, this patient did very well with the corneal GP. There was enough symmetry to this eye. The asymmetry down here was significant, but we didn't get a bubble, so it wasn't a problem to fit this patient with a corneal GP lens. Now, how about this eye? This patient is showing 13.5 diopters of corneal astigmatism, but the problem is not so much the degree of this astigmatism, it's the asymmetry. This eye is displaced inferior. We've got much steeper curvature here than we do up here. So how is that going to affect the fitting of a corneal GP lens? Well, let's put on a trial lens, KBA in this case. We'll land the lens at 9 o'clock here. Land the lens at 3 o'clock here, so this is good. We would have good lateral stability of this contact lens. It shouldn't run nasal or temporal because we've got it sitting on these rails here and here, which is good. However, in the vertical meridian, you see the problem with this eye. There is a lot of asymmetry. The surface of the eye is very low. You see that where the edge lift is kicking up. Then the eye gets higher, we have less fluid. Then the eye gets lower, we have more fluid. Then the eye gets higher, we have less fluid. Then the eye gets significantly low, and we get lots of fluid. So in this case, the patient's asymmetry across that vertical meridian is so significant that a corneal GP is really going to have a difficult time aligning to this eye and being comfortable. Now, one thing to note, at 90 microns fluid thickness, when your fluid layer underneath your contact lens is greater than 90 microns, that's where a bubble can get in there. So we're riding that 90 micron threshold right here in this area, but then below this point, in this area here, we're well above the 90 micron threshold. So there's a real good chance that we're going to get a bubble here, and a slight chance we'll get a bubble in here. And sure enough, when you actually fit that lens, you see the challenge with this eye. The eye is high, we have bearing. The eye is low, so low that we get a bubble. The eye is higher, we might just be clearing the cone here, and the eye is significantly low, giving us a bubble down here. So a corneal GP on this eye really has very little hope. Maybe a high plus soft lens, like a +4, +5, +6 silicone hydrogel with the corneal GP over might have some hope if we were to use a really small, steep RGP lens. But as a naked, just the GP lens, I don't think we'll be successful here because of the asymmetry. So that's what makes the keratoconic patient difficult, is that asymmetry. So why wouldn't we fit every patient with scleral lenses today? They're just absolutely dominating the educational symposia and the publications. Why don't we fit everyone with the scleral lens? And one of the reasons is some patients just can't get these lenses in and out. They're Fisher size, maybe they're deep set eye, there's anatomical issues that are hindering us from being able to get these lenses in. Not everyone can get a scleral lens in. Then there's the problem with the clouding. A percentage of patients, somewhere between 10 and 40% of patients will have clouding, and it's because the sclerals do not pump fluid. They trap the fluid layer in between lens and cornea, which is a good thing in ocular surface disease, but for a percentage of patients that fluid becomes cloudy, or as they describe, it's fogging. And for that percentage, it may be a bit of a pain to have to constantly take the lenses out some patients it's every hour, some as few as every 4 hours or 8 hours, but for some patients that's just not feasible. And then certainly scleral lenses are more costly than corneal GPs. So for a percentage of patients, sclerals just aren't going to work, and we're going to need to keep corneal GPs in our arsenal. But corneal GPs have a lot of issues. They're often very tight. We can have excessive edge lift. The lenses are usually unstable. They move a lot because of the corneal asymmetry. So we face a lot of challenges with corneal GPs. So how can we do a better job with our corneal GP lenses? And one of the lenses that we found to be really a performer for our diseased, our post-surgical eyes is the KBA. And this lens is a large diameter, larger than standard GPs. It's 10.2 millimeters. It has a high aspheric back surface, and it uses a really large optic zone. So we'll explain how this whole lens works. Effectively, you want a larger lens to use more of the sag of the eye and create more stability. The smaller the diameter, the less stable the contact lens can be on eye. So use more of the depth of the eye by going with a larger diameter, and that might improve the stability. So first thing we want is a slightly larger lens than we're historically using, like 8.5, 9.0, 9.5. These lenses, being smaller, are going to move more. They're going to be more unstable. Going larger, lens will move less. The less a contact lens moves, the more comfortable it is. Now, we also know that keratoconic patients have exceptionally high eccentricity values. So in the patient, in the eye on the left, you see an eccentricity along the flat meridian, the blue, of 0.86. And normal corneas have eccentricities of about 0.55 to 0.65. So this patient is 25 to 30% higher than most patients' eccentricities. The fellow eye, the right image, or the patient's left eye, has an eccentricity of 1.33, so double what might be considered normal eccentricity. Now, what is eccentricity? Eccentricity is the measure of the rate of corneal flattening. So a sphere, this green, would be zero eccentricity. It would be a perfect sphere. And I have never, in all my years, seen a corneal topography on a patient with a perfect sphere. They just don't exist. All of our eyes have some rate of flattening, or if they're post-surgical, maybe some rate of steepening. And the normal rate of flattening is 0.6 or so, 0.6 eccentricity. But keratoconic eyes have a much higher rate of flattening because they have this ectasia, this area of steepening. So from this very steep point out to the flat point, there's a much higher rate of change. So we may need to factor that into our design of lenses. For instance, if we use a perfect sphere, we use an optic zone in our rigid contact lens in this area inside the pink circle, a perfect sphere, we can land the lens nicely and create this beautiful fluid layer. But the problem is, with a spherical surface on a high eccentricity eye, you get this very acute point of bearing that you can see here and here. So you can imagine the lens impinging on the point that it creates all of its pressure. Now, if you use a high eccentricity back surface like the KBA, now you can distribute the force over a broader surface area. So now you see this really soft, wide landing of the contact lens, and that's because you're using a high eccentricity back surface of contact lens to land on a high eccentricity surface of eye. So that's one of the major advantages of the KBA, is it doesn't use spherical radii, it uses high aspheric optic zones to try to best align with the eye. And on the same cornea with a sphere on top and a sphere on the bottom, a KBA on the bottom, you can see the difference in the distribution of pressure. On the KBA, you've got this wide area of alignment on the peripheral cornea, whereas on a sphere, you get this very acute bearing point. So imagine which one would be more comfortable for the patient in terms of that distribution of force. Now, when you look at the fluorescein patterns, having a lens that follows the rate of flattening of lens to the rate of flattening of eye, you create a much wider area of alignment. So don't be concerned that you see this very wide area of pseudo-touch or possible touch. Same thing on this side, you've got this wide area of alignment. Is that a concern? As long as you've got a nice, healthy edge lift of about 0.5 millimeters width, you know your contact lens is therefore clearing the corneal apex, following the rate of flattening, creating that wide distribution of alignment, and then you get that edge lift to create the optimal corneal GP fit. So don't be concerned with the wider edge lift. It's normal with a high eccentricity back surface of lens. So when you fit the KBA, what you need to consider is I'm going to start with a larger diameter lens. I want a lens that clears the cone, that clears the opacities. We want to protect the cone. We don't want to exacerbate that cascade of problems with either the epithelium or the stroma, where it seems all the action is happening as far as the progression of keratoconus. Now, the second thing that we want to consider is having that high eccentricity back surface that creates that wide area of alignment with the peripheral cornea, and therefore a comfortable fit. So there's only two things that you need to be concerned with when you fit these lenses, or at least two things that you will focus on when you fit the KBA. Number one is I want to have a sagittal height of lens higher than the sagittal height of the cone. I want to match the eccentricity of the lens to the eccentricity of the eye. So what does that mean exactly? First, the easy one is sagittal height. We want our contact lens to be higher in height than the height of the cornea. All we want to see is definite fluorescein between lens and cornea, and certainly fluorescein over top of the cone. So if this were our trial lens and we placed it on eye with that beautiful apical clearance, this patient had a very centralized cone. You can see a lot of fluorescein in the center of this fit. So our lens is clearing the corneal apex. We're protecting the epithelium. We're protecting the diseased area from further damage. Then you've got that wide area of alignment by having a high eccentricity but a healthy edge lift. Now, let's say we put on a lens that looked like this with heavy bearing on the cone. It's a real easy fix. We need to go steeper in our trial lenses to clear over top of the cone. So fit the lens to definitely clear your ectasia. Then if you put on a lens that has excessive sagittal depth, that is creating a bubble, or we're seeing a drop in VA, then put on a flatter lens. So just go steeper or flatter in lenses till you produce a lens that has a healthy apical clearance. So what I target is a lens that is as high as you can go over top of the cornea before it creates a bubble, or before you see a drop in VA. Build in plenty of fluid layer between the lens and the diseased area, and that allows for that cone to change underneath the lens. For instance, if the patient walked in to see you with a lens that had heavy bearing on the cone and you wanted to refit them with an apical clearance design, chances are the cone would pop out a little bit. That we've been mashing, for lack of a better term, that ectasia in. We need to allow it to normalize. So by allowing for a lot of fluid layer between lens and cornea, we give ourselves a good safety valve for that cone to change, and we won't need to refit the patient with steeper and steeper and steeper lenses as we go along. So go as steep as you can before you get the bubble or before the VA starts to drop. Now, we talked about corneas not being spherical, that it is difficult to see a truly spherical cornea in the population. I've never seen one. As far as normal eyes go, they're around 0.6 to 0.65 eccentricity roughly. If you have a large cone topographer, then your eccentricity value may be more like 0.55, but normal is somewhere around 0.6. Keratoconic patients, by comparison, tend to have eccentricities greater than 0.9 e-value. Now, if you have a patient that has this very high rate of flattening, remember that zero eccentricity is a sphere. A keratoconic eye has this very significant rate of flattening. We want to place on eye a lens that follows that very aggressive radical change in curvature from center toward the periphery. So what you do then is you put on the lens and see if the eccentricity of lens matches the eccentricity of eye. Now, how do you see that? If your lens makes rule number one in that we clear the corneal apex, then you've covered half of what you need to do. The second thing you're looking at is, do I have a healthy amount of edge lift? If you've got about a 0.5 millimeter width of edge lift, then the eccentricity of lens is matching the rate of flattening of the eye. Now, we can't do much about this inferior lift that we have. This eye is a very asymmetrical surface. What you're concerned with is the horizontal meridian. It's the horizontal meridian that will dictate whether we get 3 and 9 o'clock staining. So we're focused, for the most part, on that meridian as far as the edge lift goes. Now, if your eccentricity is too low, in other words, our lens is effectively too tight for the eye, notice in this case we have a healthy amount of apical clearance over the cone, but the edge lift looks fairly thin at 3 and 9 o'clock. That means that we've got this lens landing very aggressively, too far out, giving us very little edge lift at the tip. So in this case, we'd want to call up the lab and say, I put on lens X, I want to increase the eccentricity slightly to create a softer landing, a better lens to cornea relationship. Now, if your eccentricity is too high, in other words, we've got too high a rate of flattening of lens for the rate of flattening of the eye, then you're going to get this really wide edge lift greater than a 0.5 millimeter. So in that case, you'd call up the lab and say, I want to order lens X, but with a lower eccentricity to reduce the edge lift. So your KBA set comes in a number of different eccentricities, and that's because we know normal corneas fall within ranges of 0.6 to 0.8 roughly. Globic cones tend to be higher, 0.9 to 1.1 eccentricity. Oval cones, the majority of eyes that you're going to see are between 1 and 1.2 e-value. And then your central ectatic nipple cones tend to be very high eccentricities, more like 1.2 to 1.6 eccentricity. So your fitting set comes in two different eccentricities, 0.98 E and 1.3 E. And the idea is you've got the majority of lenses being the 0.98s because that's the majority of eyes that you're going to see. Now, you can fit the lens by any method, either keratometry, topography, or if you have the Medmont, you can fit the lens right out of the fitting software. Let's go through each. First, by keratometer, if you don't have a topographer, all you do is take your flat K, convert it to millimeters. So if our flat K were 4250, that would be an 804 millimeter radius. We subtract 0.6, tells us we need about a 740 base curve trial. You can be miles out. Ultimately, once you put the trial lens on eye, it'll tell you, do I need to raise the sag, lower the sag. So don't be worried that this is a fairly unscientific method of choosing the initial lens. We've got to start somewhere. Now, what if you have a corneal topographer? Well, you've got a couple things you can look at. You can click your cursor on the steepest radii, in this case 53 diopters or 6.37 millimeters. I would subtract 0.6 millimeters from the steepest radii, so that would give us a 580 or about a 580 radii if we subtract 0.6 millimeters from 637. We could also look at the eccentricity of this eye, and it's measuring 0.86 along the flat meridian and 0.71 along the steep meridian. So that tells me that the 0.98 eccentricity trial lenses are closer in e-value to the eccentricity of this particular eye. Now, if you have a Medmont topographer, you can fit the KBA right out of your fitting software, and that allows you to manipulate the fit to create an optimal relationship before you even put on a trial lens. It also allows you to see, can I even have hope with the KBA? Is this keratoconic eye so asymmetrical that a corneal GP would be a waste of time? So it's a very efficient way of fitting these lenses. But it doesn't matter what you have, whether it's a keratometer, a regular topographer, or a Medmont topographer, no matter what you have, ultimately it comes down to putting a lens on eye, going steeper or flatter in trials to optimize the apical clearance, then observe that eccentricity. Do I have the right rate of flattening of lens to rate of flattening of eye? And you can see that from the amount of edge lift. Now, because the KBA is slightly larger at 10.2, and you can make it smaller or larger, because it's a high aspheric and slightly bigger than the normal GP, it fits quite a wide range of eyes. Now, I've noted a huge range of both diseased and post-surgical eyes. Can the KBA fit all of these patients? The answer is yes and no. Yes, if the asymmetry isn't too high. If the asymmetry is so high that we're going to have these wild swings in bearing and vault, then you need a scleral lens or a piggyback. But if the asymmetry is moderate, then there's a good chance that we can fit the patient with a KBA, a corneal GP lens. So you can always try it on any patient. Just go 0.6 millimeters steeper than the flat radii of the eye. And if you have topographer, you can be a little more scientific about it. Now, for those of you who haven't been able to attend the previous webinars, if you go to YouTube and search for Precision Technology Services, you can find the previous webinars that we did. And for all of you logged in tonight, we will send you a link to tonight's video. If there's anything that you wanted to look at again, you're more than welcome to just go through the webinar a second time. Now, the next webinar, number 5, is coming up on March 4th, and it'll be devoted to scleral lenses. So this should take us from a sort of conventional fitting corneal GPs that many of us are familiar with to fitting the modern scleral lenses. And I have to be honest, at Pacific University, where I work part-time, scleral lenses are our lens of first choice. We still keep corneal GPs because some patients can't either insert them or remove them. Some patients get that fogging that I talked about. So we always want to keep our corneal GPs, but it's really the industry is going toward scleral lenses these days. Now, for those of you who are interested in scleral or specialty contact lenses, we have 2 workshops coming up in both Vancouver and Toronto, March 7th and 8th in Vancouver, March 14th and 15th in Toronto. Friday evening will be in both sites will be the evaluation of live ortho-K patients. Pat Caroline is going to do his awesome talk on myopia control, and we'll look at all the pre-treatment ortho-K procedures. Then Saturday morning we're going to do live follow-up with the patients. We're going to talk about how you use multifocal soft lenses as myopia control devices, how you use RGP lenses, conventional RGPs, as myopia control devices. And then in the afternoon, we're going to talk specifically about scleral lenses, and we'll also possibly be fitting patients, but definitely we can put the lenses on each other. And if you've never inserted or removed or felt the scleral lens, it'll give you an opportunity. Many of you have probably put corneal GPs on in lab. You know how they feel. A scleral lens is an 8 or 9 on a comfort scale for a new wearer. An 8 or a 9 on a comfort scale is the same as what a soft lens is. So you will be shocked how comfortable these lenses truly are. So I'd like to thank you very much for joining us tonight with the webinar on corneal GPs. I'll welcome you to stay on for the question period, and thank you very much again. Next question is your lens of choice for post-LASIK and post-RK also a scleral lens? And again, I think it would go back to the asymmetry of the eye. The scleral lenses are just so darn comfortable that for sure you really want to pull it out, because you know with the scleral lens you can guarantee 2 things. right off the bat as soon as it goes on eye. Number one, it's probably not going to move all that much. It's going to be centered, where we can't always guarantee on disease, post-surgical, and post-refractive surgery eyes that we can center a corneal GP lens. That's one of the problems that we face. So you've eliminated centration as a problem immediately as soon as you start with the scleral lens. And then as far as the asymmetry goes, if the eye elevation changes are under that 400 micron mark, then a corneal GP has a real good hope. If it's a really oblate surface, in other words, a real tabletop center versus steep mid-periphery, KBA is probably not, even with its high asphericity, is probably not going to accommodate the post-LASIK, or the, let's call it the 10 diopter LASIK, or the significantly oblate RKI. That's probably a scleral patient. But would certainly try corneal GPs if the asymmetry isn't too low. One of the questions was, if you don't have a Medmont with its fitting simulation software, what's your preference, empirical or trial fitting? We always have to use the trial set. I'm sorry, I guess you don't always have to use the trial set, but as you know, in keratoconus, we have to over-refract these patients. It's very difficult to empirically order lenses for these eyes. So you might as well put a trial lens on eye to confirm that, number one, you've got an appropriate fit, you've cleared the corneal apex, you're landing appropriately, you've got the right eccentricity, and then just as importantly, what's the over-refraction on these really asymmetrical shapes. For those of you who are joining us from the U.S., the Essilor contact lens carries the KBA in the U.S. Precision Technology carries it in Canada. I see we have some Australians. As you know, the KBA lens is available from Capricornia, designed, of course, by John Mountford and Don Nowak, and used all over the world. Poor fitting lenses are implicated in keratoconus, too tight or too flat. It's more likely too flat. The CLEK study indicated that 80% of the lenses fit on those 1,200 patients that were evaluated were too flat. So the assumption would be they were hitting the cone. We also found with the CLEK study that the incidence of staining and scarring was significantly higher with the flat-fitting lenses. The incidence of staining and scarring was significantly lower with lenses with apical clearance. So you can certainly have apical clearance but a tight periphery, but that may not produce staining where the lens is landing. So we're much more concerned with bearing of the lens over the ectasia. That's the big concern. One of the questions was, if we prefer scleral lenses, how do we present these large, very intimidating lenses for patients? And one of the things that we might say to them is that corneal GPs are easier to get in and out. The solutions that you deal with corneal GPs are much more straightforward. As you know, with corneal GPs, we really only need, let's say, Boston Advanced cleaner and conditioning solution, and that's it. Whereas with scleral lenses, we need preservative-free saline for rinsing and insertion. We need GP fluid for surfactant cleaning and overnight soaking. So there's a lot more complications. The solution cost is higher with scleral lenses. The lens cost is higher with scleral lenses. So there's advantages both ways. The corneal GP is, it pumps fluid very well. It's easier to get in and out. It's more inexpensive. The scleral lens is going to be instantaneously more comfortable and more stable on eye. So the adaptation to a scleral is much easier. But as far as intimidation, I don't know that we have that much trouble with patients being concerned with the size of the lens. I will say, though, with scleral lenses, getting them on without a bubble on some patients can be very tricky, and it can take multiple attempts. So I find that a bigger issue rather than the size of the lens, to be honest. I think they do cross-linking under 400 microns. by hyperosmotic solution. Dr. Pop in Montreal. Okay, interesting. Well, good to know. We certainly know that cross-linking is evolving. So it's good to know that we can start seeing some of these patients that are progressing very aggressively, and try to keep that keratoconus under control. So that's good news. Thank you very much. One of the questions was, have we, with the new soft keratoconus lenses like the Novacone, the Kerasoft, the Soft K, are we using more of these lenses in practice versus, let's say, Corneal GP or even scleral lenses? And the answer is definitely yes. We're pulling out the soft keratoconus lenses much more. They are a bit tricky to fit compared to sclerals, in that you don't have to worry about the astigmatism and rotation of the lens. However, that factor is probably pretty low. The nice thing about the soft lenses is that they pump fluid where the scleral lenses do not, so we don't have the fogging issues that sclerals do, so that advantage to the soft keratoconic lenses. They're very thick, so that's edema is always a consideration. So that's something to keep our eyes on with these lenses. Versus we don't have edema problems with scleral lenses. But yeah, I think soft keratoconic lenses are going to be a much bigger part of our practices going forward. Well, everybody, that was an hour of logging in. I sure appreciate your time tonight, and anything that comes up as questions, please let me know. You're more than welcome to email me. And if you're interested in any of the upcoming webinars, just let us know, or actually by being involved tonight, you'll automatically receive the invitation to the next lecture. But if you're interested in the Ortho-K and myopia control workshop, then please let us know, and we'll send you more information. So thank you very much, everybody, and have a great evening.